Good morning, everyone. Thank you, Mr. Chairman. And I would like today to thank the organizing committee for giving me the chance to stand here today to talk to you about the sonographic assessment of thyroid nodules and what ultrasound can tell us in this issue. If we start by the anatomy, we all know that the thyroid gland is located at the lower part of the neck. It extends from the level of C5 vertebra down to the level of the T1 vertebra. It's formed of two lateral loops connected together by an isthmus, and the isthmus lies opposite the second to fourth tracheal ring, and sometimes we can see the pyramidal lobe, which is seen extending to the hyoid bone. The average width of the gland is about 1.5 centimeter for each loop, and the average height is 5 to 6 centimeter. The weight varies between male and female, with average weight in an adult male 25 to 30 grams, and it's slightly higher in females and got bigger during pregnancy and menstruation. The ultrasound, when we do the ultrasound, we ask the patient to lie in the bed with the neck hyperextended, quite uncomfortable for the patient, but actually this is necessary for doing the examination. We use a high-frequency probe, which transmits a high-frequency sound waves that will be reflected by the thyroid and neck tissues in the form of echoes, and hence the name echogenicity, to form the image that we are going to see on the monitor. This is the normal appearance of the normal thyroid gland, in which you can see the trachea here in the center. In front of it lies the isthmus and the both thyroid lobes on each side, with the common carotid artery posteriorly, and more lateral to that will be the internal jugular vein. This will be covered by the strap muscles and the sternomastoid muscles. So what is a thyroid nodule? For a clinician who's doing an examination for the patient, thyroid nodules means that an abnormality in the form of lump or irregularity that he can feel by hand. But when we go to the radiological definition of thyroid nodule, it means that that part of the thyroid gland is different than the surrounding. And that's what we call it a thyroid nodule, like this hypoechoic nodule seen in this thyroid loop. Keep in mind, not always what you feel by palpation correspond to a true thyroid nodule. Like in this example, if we do palpation for the patient here, you will find that there is a bulge at the right thyroid lobe in conjunction with the isthmus, and this is not a true nodule, but just a pseudo-nodule formed by bulge of the thyroid tissue. Non-palpable nodules can be detected in ultrasound or imaging modalities done for other reasons, for imaging of the neck, and these, which are incidentally discovered, carry the same risk of malignancy with the palpable thyroid nodules of the same size. So why we are concerned about the thyroid nodules? Thyroid nodules are actually a common clinical problem. By palpation, we will find that about 5% of females and 1% of males will get a thyroid nodule. This is especially in iodine, we are talking about the iodine sufficient parts of the world, while by high resolution ultrasound, the number will significantly increase to about 67 to 19 to 67%. And the clinical importance of that about 5 to 15% of these nodules are malignant. We can see this graph, which was introduced in the early 90s of the previous century, in which you can see that the prevalence of thyroid nodule increases with the age, and the number of thyroid nodules detected by ultrasound or autopsy after thyroidectomy is much higher than what's detected by palpation. A nice number to remember that by the age of 50, about 50% of the population will have a thyroid abnormality. So why we are missing the nodules in palpation? We can miss it either due its posterior location or to the small size. Like in this example, a small nodule, posteriorly small, not causing any bulge on the anterior surface of the gland, so it will not be palpable. And this one, of course, it will be palpated when you do examination of the patient. And as you see here, whenever the size of the nodule is smaller, the percentage or the chance that this nodule will be missed by palpation is higher. For nodules less than 1 centimeter, there is a chance about 94% that it will be missed. So what are the types of thyroid abnormalities we see on biopsy? What will be the results? Most of these nodules will be benign. About 70% will be benign hyperplastic nodules, 10% benign thyroid adenomas, 5 to 12% will be thyroid carcinomas with different size, papillary, follicular, medullary, and anaplastic. And in 1 to 5% it can be just a focal area of thyroiditis or unusual lesions like intrathyroid parathyroid tissue, true cyst, or metastatic disease. From what I said previously, you know that now it's very important to do a thyroid ultrasound for any patient with suspected or known thyroid abnormality. And this is the recommendation actually of the American Thyroid Association, the revised criteria, which was published in 2009. Why we care, or why we are doing the ultrasound, what will happen after we do the ultrasound, the most important question will come to our mind is to take a biopsy or not to take a biopsy. And actually, in order to answer this question, we have to keep in mind many factors, including the risk factor the patient is exposed to, like radiation during childhood, positive family history of thyroid cancer or multiple endocrine neoplasia, also the sonographic assessment of this nodule, and the least is the size of this nodule. And in other situations, when you find multiple thyroid nodules, which one you will go for biopsy from? Is it the larger or what? And that's what we are going to see now by going through the ultrasound characteristic of thyroid nodules. To characterize the thyroid nodules, there are several characters that we were going to go through them very fast. I'm going to just enumerate them: the calcification, echogenicity, the margin, the shape, and the vascularity, invasion of the surrounding, and the presence of a enlarged lymph node in the neck. I'm going to start with the calcification. Just keep in mind that calcification can occur in benign and malignant diseases. We can classify them into microcalcification, coarse calcification, and peripheral calcification. The microcalcification, as in this example, you can see this white dots, what's called the punctate calcification without posterior acoustic shadowing. This is the most specific feature of thyroid malignancy, with a specificity about 95%. The most common, it occurs in papillary thyroid cancer, but it can occur in other types of cancer like the follicular and anaplastic, as well as in the benign conditions like in cases of follicular adenoma and Hashimoto's thyroiditis. If these punctate calcification has what's called the comet tail artifact, as you see here, this is usually associated with colloid cyst, and this is a sign that this nodule is likely to be benign. Dystrophic or coarse calcification can occur with thyroid nodules, most commonly with multinodular goiter, but keep in mind if it occurs in a solitary thyroid nodule, there is a chance 75% that this thyroid nodule can be malignant. Most type of this cancer will be medullary thyroid cancer. Previously, we thought that the peripheral calcification is a sign of being benign, but now this has been changed, especially if this calcification is interrupted, and it can occur with cancers. And this is two examples of papillary thyroid cancer showing interrupted peripheral calcification around the thyroid nodules. We care also about the margin, the contour, and the shape. For example, the halo. The halo is this dark line surrounding this nodule. It's no more than compressed surrounding tissue, so it's just a pseudocapsule. It is a high specific sign for being benign, but keep in mind that 50% of the benign nodules will not have these features. Moreover, about 25% of papillary thyroid cancer can have a halo, either complete or incomplete. Ill-defined margin, like this one, infiltrative margin, is also a sign of being malignant or suspicious feature for the nodule. Another sign which was described with high specificity for being malignant is when you measure the thyroid nodule in the transverse scan, and you will find that the anteroposterior diameter is more than the transverse diameter. This is a sign for malignancy with the specificity around 93%. Vascularity, after we finish our examination, usually we turn on the color Doppler to see what's the vascularity of the nodule. The most common type of vascularity that we see inside a malignant nodule is the intrinsic hypervascularity. But keep in mind that not all hypervascular lesions are also malignant. On the other hand, perinodal flow, which is defined about 25, at least 25 of the circumference of the nodule will show this increased vascularity, is a sign of being malignant, but unfortunately it can happen also in 22% of thyroid cancers. Completely avascular nodule are unlikely to be malignant. The echogenicity. Most of the papillary thyroid cancers, most of the papillary thyroid cancer are hypoechoic. However, because most of the most common lesions inside the neck, as we said, are benign nodules, and some of them are hypoechoic, the most hypoechoic nodules that you're going to see are benign. But if you go for multiple papillary carcinomas and you retrograde so what they looked like, they found that most of them will be hypoechoic. And this features is, although it's not that specific for being malignant, it can be of more specificity and sensitivity if it is combined with other features like the solid consistency, the calcification, and the intranodular flow. Invasion of the surrounding, like in this example, in which you can see that the hypoechoic nodule has invaded the capsule and extended outside the gland with this microcalcification. This is a highly specific sign for being malignant. Metastasis in the cervical lymph node can be the only sign that will make you think that a thyroid nodule that doesn't carry the suspicious features could be malignant, and will let you do a biopsy from that, because metastasis to original cervical lymph node can happen in about 20% of the cases. Most common in papillary thyroid cancer. In medullary thyroid cancer, 50% will have metastasis at the time of the presentation, while it's rare with follicular thyroid cancer, even in the advanced stage. The features we are looking at in a lymph node, the round shape, the increase in the size, the replacement of the fatty hilum, irregularity of the margin, heterogeneity of the ecotexture in the form of calcification or cystic changes, and increased vascularity through the lymph node instead of just increase at the central hilar vessels on color Doppler examination. Here are some examples: rounded lymph node, loss of the hilar fat, increased vascularity, and multiple cystic changes. All these are suspicious. So, to summarize, sonographically suspicious nodules can appear hypoechoic, irregular margin, punctate calcification with intranodal flow, and these are different examples for that. While the benign appearing nodules will be iso-to-hyperechoic with a nice halo around, smooth margin, and peripheral vascularity. Keep in mind that completely cystic nodule, most likely they are benign. And the spongiform nodule, which is a nodule that have more than 50% of its consistency formed by small microcysts, have a chance of being malignant less than 1%. To summarize, from this table you can see that always some of the features have a high specificity, but the sensitivity is low, especially for microcalcification has a high specificity, taller than wider, and marked hypoechogenicity. If we combined multiple features of this together, the specificity will rise, but the sensitivity will still be low. And in order to have a proper diagnostic test, it has to have a high sensitivity and high specificity, and we can see this in the fine needle aspiration biopsy with a sensitivity around 92% and specificity around 84%. And this graph shows us the stratification of the urgency for doing the fine needle aspiration biopsy. And you can see that as we move to the right side, to the left side of the graph, you will find that the biopsy will be strongly indicated. If we started from here, purely cystic and spongiform, they carry a very low chance of being malignant, while with high-risk patients with suspicious ultrasound feature, this is strong features for going for fine needle aspiration biopsy. This table was introduced by the American Thyroid Association in 2009 and show a correlation between the ultrasound features of the nodule as well as the clinical features in the form of the risk the risk of this nodule to be malignant based on the history of the patient, as well as at which level we should go for fine needle aspiration biopsy. For example, if we go for this part here, you'll find with high risk history nodule with suspicious sonographic features, we go for a biopsy when the nodule is just more than 5 millimeter, while we don't go for this cut off if there is no previous risk or high risk history for this biopsy. On the opposite side here, you'll find with a spongiform nodule that we go for that above 2 centimeter, and the recommendation for that is C, while for pure cystic nodule, we go also above 2 centimeter, and the recommendation for that is C, not as urgent as this one, which is an A category. Why do we do the fine needle aspiration under ultrasound guidance? We do it in certain situations if it is difficult to palpate the needle, to palpate the nodule. If the nodule is not palpable and it's only found by ultrasound but meet the criteria for fine needle aspiration. And we do it for posterior located nodule because simply you can just go by palpation and sample the anterior part, which is only the normal thyroid tissue. And we also go for that if we did before ultrasound, we did biopsy by palpation and turned to be benign, and we still feel that it's suspicious, we go for by ultrasound guidance. To summarize, ultrasound is valuable for identifying many malignant or potential malignant thyroid nodule, but there is some overlap between the features between benign and malignant lesions, and taking the sensitivity and specificity of each one and combine them together, this can give us a better idea about when to do a biopsy. FNEC is highly sensitive and specific for the diagnosis of malignancy, and FNEC of thyroid nodule should be based on many factors, including the risk factor, the sonographic appearance, as well as the size of the nodule. Thank you so much.